While I would have loved to join you in your Congress, unfortunately that wasn't possible, but I'm still honored to be invited to the podium to talk about robotic tar. These are my disclosures. In the interest of time, I wanted to show you as much as I could within the time constraints, so we'll just jump right into the video. This is a 70-ish year old male who presented to my office with multiple failures after IPOM incisional hernia repair. You can see on the CT scan, you can see areas of incarceration in which he had small bowel obstruction. We did effective prehabilitation. He lost significant weight prior to surgery. And then we booked him. So the case started out dissecting adhesions off of the intraperitoneal mesh. This was about 2 hours in duration. Normally, if the mesh is well adherent, well incorporated into the abdominal wall, I typically don't do anything with it. So we start off, I have ports on the left side. We start off with the incision of the posterior sheath. And we do that cephalad caudad to our suprapubic crossover flaps, and that provides me access all the way down to space of Retzius. We do retromuscular dissection to the EIT junction or the lateral rectus. You can see the position of the neurovascular bundles. That always points towards the head, so that is the left rectus. Sorry, that's mislabeled, but that is the EIT junction as described by Philip Moisems. I like to start off bottoms up. We go down, dissect into the preperitoneal space of Bogros. We've identified the arcuate line, and then we dig a cave separating the posterior elements, that being peritoneum and transversalis fascia, off of the lateral posterior sheath, which represents the aponeurotic portion of the transversus abdominis in the lower abdomen. I like to create this V, like you can see here. We divide the aponeurotic portion of the TA, which is medial to neurovascular bundles, medial to the EIT junction. When you get to the mid-abdomen, the peritoneum starts getting thin. That's when you can start bouncing into planes. There, I'm in the true pretransversalis space. And that leads us to the upper abdomen. You can see that TA ridge. That is formed by the muscular fibers, the TA and diaphragm, inserting more medially on the posterior sheath in the upper abdomen. You can see the different layers of the abdominal wall. And essentially what I'm doing is I'm exploiting those layers based on the integrity of the flap. This is the second way you can do TAR. This is per the Nowitzki way. In the upper third of the abdomen, you divide the posterior lamella of the internal oblique. Then you divide the transversus abdominis to the transversalis fascia. And I say you cut this TA, the muscular fibers of the TA, like a Heller, trying not to make holes in the transversalis fascia. And then you do pre-transversalis dissection all the way down to the retroperitoneal fat. Once you're in this fat area, you know, I like to say go lateral, lateral, lateral. When your area of dissection cones in, you widen out the flap. This is what you need to see, the critical view of TAR, cut edge of TA on the abdominal wall, cut edge of TA on the posterior sheath. That's the sentinel fat. That is a nice landmark to the diaphragm. And what you'll notice is the costal diaphragm meets pars abdominalis as described by Laurier and Miguel Angel Urena. The pars abdominalis is an extension, cephalad extension of the posterior sheath and forms the boundaries of the foramen of Morgagni, as well as converging onto the central tendon. Here, I like to have my residents connect retroperitoneal planes between the bottoms up and Nowitzki style. You can see the costal margin there, you see the TA. Now we start with some retrosophoidal dissection, but you can see the cephalad extent of the TA becomes the pars abdominalis, and you can see that right there, that muscle, that diaphragm, and again, that will form the boundaries of the foramen of Morgagni, as well as you can follow those muscular fibers all the way to the central tendon. This patient had an incision that extended from the xiphoid process all the way down to the suprapubic space, which buys him a trip to central tendon, as well as buying him a trip to the space of Retzius. So that's the extent of my dissection. Once I'm done with one side, we place 35 by 40 centimeter sheet of mesh after measuring. We secure the mesh, we place other trocars, so then we rotate the boom and we perform contralateral dissection. So this is over the patient's right rectus now. We divide the posterior sheath along the medial rectus, and in the cephalad and caudad extents, we connect our suprapubic flaps. So on each side of the abdomen, we have retromuscular dissection, but at each apices, we have a suprapubic crossover where you can dissect in the preperitoneal space down to the space of Bogros, which is down here, as well as you can dissect all the way down or up towards the central tendon by dissecting the epigastric flap crossover. Here in the lower abdomen, it's a little stuck secondary to probably IPOM tax. You want all that fat up in the lower abdomen. That's fat that's supposed to be guarding the epigastric vessels. And now I'm trying to find space of Bogros, or the resident is trying to find that to start bottoms up. So retromuscular dissection, again, you can see the neurovascular bundles pointing up towards the head. That's a nice landmark to orient you in space. And now here you see the arcuate line. You divide the transversalis fascia to get in the preperitoneal space. That's the space of Bogros, visualizing the TA on the lateral abdominal wall. And then we dig a cave, forming that V, going bottoms up, dividing the aponeurotic portion of the transversus abdominis muscle. Here's what I say, teach all the residents. Left hand tells where the right hand goes and the camera follows. So you're always at a fixed focal length, and you're always operating in the center of the screen. You dissect all the way to the retroperitoneal fat. Here I'm doing a Nowitzki in the upper abdomen. Again, dividing the posterior lamella of internal oblique, dividing the transversus abdominis muscle to the transversalis fascia. There's the sentinel fat in the contralateral side, indicating that we're by the diaphragm. And then we just complete our TAR and do pretransversalis dissection to retroperitoneal fat. There you can see the pars abdominalis again, extending from the posterior sheath. And you want to make sure that there's no muscle on the floor. You want to make sure that that diaphragm remains up, or you can all of a sudden be in the mediastinum. And then now we complete retroxiphoidal dissection. I am buzzing that retroxiphoid fat ball. There's a lot of vessels that are in there. And I'm going to central tendon, as you see. Here's, I have to complete, join the pedicle of the Nowitzki TAR with bottoms up TAR, and then again all the way down to the retroperitoneal fat. So we use a 2-0 barb suture to close the posterior sheath. In the bar, out the bar, cross the street. Close that in canal fashion. Now we're working from suprapubic going up, closing the posterior sheath, a modified canal technique here. We suture the 2 barb sutures together, and now we close the anterior sheath. This again was a 15 by 24 centimeter divarication, a multiply recurrent incisional hernia, and you can see at a pneumo of 8, this defect comes together without undue tension. This is how I cinch. Least traumatic way of cinching is parallel with the abdominal wall and into the camera. So we start up top, go low, fast forward this. You can see the linea alba is reconstituted, rectus back in the midline, and then we suture trick by rolling that suture all the way to the contralateral side, tucking that into the space of Retzius, tucking the cephalad aspect to the central tendon. I always leave a retromuscular drain, and then we desufflate. Patient was admitted, discharged on post-op day 1, was without narcotics. I've seen him in 3-month follow-up, and he's doing very well. Thank you very much. Wish I could join you, and hope you're having a great Congress. Bye.